This talk is on multifocal ERG, more from a clinical perspective rather than an electrophysiologist perspective. We do see almost lot of our patients coming with these printouts to us. So as clinicians, we should know what to make out of these printouts. Dr. Shubhadra already spoke about ERG, about electroretinogram, which is essentially a mass response, which means the entire retina response. What do you do in cases where there is a focal problem? How do you detect that electrophysiologically? That's where multifocal ERG comes, where you have responses from local areas. So what is essentially done is you have this kind of a stimulus pattern with small areas, separate stimuli, which gets responses from small focal areas of the retina. And that comes out as a trace here and in different patterns. We'll see how the printout comes as. And these small waveforms are what constitute a multifocal ERG. Now, if you look at each of these waveforms, it has a typical pattern. It has a waveform which we label as N1, P1, and N2. These are something called as first order kernels. Don't get into what these kernels essentially means by waveforms. And if you compare this with the ERG waveforms, the N1 is contributed more or less similar to what you get in A wave in an ERG, and the P1 is contributed from similar cells like the bipolar cells what you get in an ERG pattern. But this is not really an ERG pattern because this is more of a mathematically derived waveform what you get here in a multifocal ERG. What we are going to look at is how we essentially do this test. What are the stimulus, what is the electrode? You need to have a background knowledge about these things to interpret the test. Recording techniques, how the printout comes, what are the different waveforms that you see, interpretation, a brief word on that, and indications for doing this test. Stimulus is either a cathode ray tube or an LCD monitor like you see here, in which this pattern comes. This pattern consists of multiple hexagonal pieces here, hexagonal pattern. It can be either 61 or 103 hexagons. You can have more, you want to get much more details, you can have more, but makes the recording time much longer, makes the recording interpretation much longer. This is more or less enough for a clinical usage. These are scaled. What it essentially means by scaled is the central ones are a little smaller than the peripheral ones, essentially done to get a similar sized waveform of all areas. So if they're the same size, then the central thing, because of the more cones, more functionality there, you get much larger waveform. So it is scaled essentially to get similar waveforms throughout. And it covers about 40 to 50 degrees of the central field, a little more than your visual field. Now each hexagon is an independent stimulus and it changes from light to dark in a different, it's not light, dark, it's a different pattern. It's a fixed pattern which they call as a pseudo-random M sequence, where you may have dark, light, or that particular sequence. Now all of the things go through the same sequence, except that the starting point is different for each. So they all appear to be at a different time in different settings. So it's almost like it's flickering. So you have this much at the same time you get, and that's from that ERG is derived in that. What you essentially do is the entire response is graded, and you get a one continuous ERG waveform from which responses from each hexagon, depending on the sequence, the machine mathematically derives those waveforms from individual areas. The electrodes are very similar to what you use in ERG. You can use a Barina electrode or the DTL or the other electrodes. What you essentially have to have is a clear visual axis. You need a full pupillary dilatation with this. Pupillary size does affect the waveforms. Light adaptation to room light for about 15 minutes before the testing. Patient comfortably seated. Electrode place extremely essential for the patient to have a good fixation. If the fixation is not good, you're going to misinterpret this waveform. So this is probably one of the most critical steps in doing the test, while doing the test. And this is what is important for you as clinicians when you're interpreting the test. First thing is look at the fixation. Is the fixation good? Then you can go ahead and interpret the test more sequentially or more logically in that way. Refractive error does affect to some extent, not a very strong criteria. They have some studies have shown up to plus or minus 3 doesn't have much of effect, but we prefer to have it because there are studies which show that it does affect the waveforms. Room light is kept on. Whatever test we do is essentially for cone functions. We don't assess rod functions. It's more of a cone-driven waveform, mainly because the light adaptive conditions we do in the reputations of the stimuli that is used, only the cones are capable of responding here. Now what printouts you get, what printouts you see, you can have either what we call as a trace array, or you can have something called as a 3D plot. And sometimes we do averages, and different averages are there, what way to averages are there. Trace arrays are what you see, this multiple waveforms. This is what we call as a trace array. This is a very basic waveform of a multifocal ERG. All your printouts should have it. Don't try to interpret a waveform without this. It gives you actual visualization of the areas. Somehow a little more difficult to see this, any variations in the waveform because of so many but the machine does a lot of things for you. It calculates the amplitude, it calculates the implicit times, and tells you a lot about these waveforms. This is, just to give an example, this is a young patient with a reduced vision, has some subtle changes here. Full field ERG, very, very normal, but when you do the multifocal ERG, you can explain the visual loss by the central pulse. This patient has Stargardt's. So it helps you to detect spatial variations. That means if this part abnormal, it can tell you on the multifocal ERG. If the central part is abnormal, it will tell you on the multifocal ERG. So that's one way in which you can use a multifocal ERG. The second display is what we call as a 3D plot. This is something which we are used to based on the other tests that we do in ophthalmology. Easier to interpret. This gives you the spike. This is where you get the maximum peak at the fovea. This gives you other areas. This is what a normal spike will look like. Important to note the blind spot, what you see here. That tells you a lot about the fixation. If you don't see this spot, that means the fixation has not been very good in the patient. So this is the primary use of a 3D plot, and then you can correlate with the other tests. Try not to use this plot alone to interpret a test. Use it always in combination with the trace array. Now here you are using a combination, the same case that we saw earlier, where you have a central vision and you see the 3D plot. So it matches quite well. So you know there's some problem in the central macula, and then you go ahead and investigate further to try to find out what exactly the problem is. This is another patient with retinitis pigmentosa who had more diffuse changes reflected on the multifocal ERG and both the trace array and the 3D plot. Another patient is a central problem where there is a central reduction in the amplitudes and the central loss of the peak that you see here. Now, we saw the trace array, we saw the 3D plots. To get more information from multifocal ERG, you can actually average responses from different areas. One way of doing it is something called ring averages, where this entire area is divided into multiple rings. You can label it as R1, R2, R3. The responses in this particular ring are all averaged and then displayed. So you can have average for this entire ring with this ring, and it can be displayed in 2-3 ways. You can have something called as response per hexagon or response per degree. That depends on what your machine does or what you ask the machine to do. And this is a plot where you have the trace array, you have the 3D plot and the ring averages. This is color coded a lot of times. Some of the machines do that, where you know this is from the central area, this is from the, so that if you have the normative values, you know what is abnormal, what is not abnormal in that. One place where they have found ring averages useful is in patients with HCQ toxicity. There they have found this particular ratio, R1 by R2. If this is increased, there is a higher likelihood that the patient may be having HCQ toxicity, but you have to take 2-3 things into consideration, not just one test and probably label it as that. So this may be one application of ring averages. The averages can be done in different ways. You can have averages from quadrant-wise, half the maculas, or you can customize it to, depending on what your machine allows you to do, different areas you can get averages of response. Second order kernels I'm not going to get into because not much of clinical applications as of now. Earlier it was thought to be related to glaucoma changes, but there has been a lot of dispute about that. We are not using it for clinical purposes right now. So where do we use multifocal ERGs? Most of the time when you're using multifocal ERGs, the full field ERGs are usually normal in these patients. You still don't know what the cause for the visual loss, and you want to know the visual loss. Now you need to know whether the visual loss is because of a retinal problem or an optic nerve problem. This is a useful test. This gives you impulse, any problems in the photoreceptors up to the bipolar cells, it will tell you there's a problem. Ganglion cell abnormalities will not, you will get a normal ERG here, normal multifocal ERG. So anything more central, you're likely to be an optic. If your patient has a reduced vision, has a normal multifocal ERG, more likely to be a more central problem, more likely to be an optic nerve problem. So in these cases where you have a patient with a reduced vision, you don't know the cause, we don't know the exact pathology, what is there, helps you. It's one of the tests which will tell you whether it's a retinal or a central neurological issue, and helps you to take it forward. Distinguish between retinal diseases. If you really go into the details, you can try to differentiate between photoreceptor disorders, inner bipolar disorders, based on whether the amplitudes are more affected or the implicit times are more affected. Progression of any retinal diseases, you have a condition, you have the baseline multifocal values, follow the patient, see how it is following up. This is probably a good indication for doing a multifocal ERG. Drug toxicity. One of the recommendations in patients with STQ toxicities is to do a multifocal ERG also. Indications are few, but if you know what you're doing it for, we generally don't ask this test for routine cases. It's very, very specific indications where you'd like to know what is there. Not a good idea to do it in all the cases, because a lot of times it throws up values, you don't know what to do with this. Everything is okay, multifocal is abnormal, you don't know how to proceed after that. So you should know why you're asking the test and then get the test done in that time. And this is just to summarize everything. You check the clinical details of the patient. Once you have the multifocal, if you have a printout with you, go through the clinical history, why the test was ordered, how you think the multifocal ERG is going to help you. Look at the 3D plot, look at the trace arrays, study the trace arrays, correlate with the 3D plot, everything going ahead, you know the recording is okay. If required, group averages, and always try to correlate it with the other findings, the clinical findings, especially the visual field findings, gives you a lot more information. In cases of HCQ toxicities, you have done a multifocal ERG. Now, most electrophysiological tests are subject to artifacts, are subject to recording errors. So always try to correlate with visual field. If you do a visual field in the same area, you're seeing a visual field defect, yes, 10-2 you have done, then it's probably more in favor of an HCQ toxicity. Based on this test alone, if everything else is alone, I would probably suspect it, but still observe it, would not probably just stop the medications just on this. So this was about multifocal ERG. Very briefly about EOGs, we are doing less and less of this test. It is the only indication used to be best dystrophy. Now we are relying more on OCTs and genetic studies to diagnose this. And EOG is basically a record of the standing position that exists between the cornea and the back of the eye. Tests RP layer and arises from the ion permeability changes across the ion channels in the basal RP membrane. It's not constant, it's a changing potential. You light adapt the patient, the potentials will keep changing. You dark adapt the patient, it keeps changing, and we make use of these variations to record the EOG. Electrodes are attached like this, and the patient is asked to move the eyes from one side to the other eye, so that the cornea goes from one side. That's the positive and the negative, which keeps going from one shift to the other side. And what you essentially do is you light adapt the patient where you ask him to do the test, so he's used to the test. You switch off the light and take a recording after every minute, and that is plotted. So after every minute you've taken a recording, those potentials are plotted. At the end of about 10 or 12 minutes, you get the lowest value, what we call as a dark trough. And then you switch on the light and the amplitudes go on increasing, where you reach called a light peak. And the ratio of the light peak to dark trough is something called as an NitinS index. And this is how a waveform looks like. This is something which the waveform, if you plot it, it's useful to look at this waveform. This particular arm is what we call as a light rise. So if this is not there, you know that it's not normal in that arm. And NitinS index, these are the standard values. Anything more than 200 is considered normal. Between this range is borderline. Most of your best dystrophy will have very low amplitude, very low NitinS index. This is what your standard EOG report will contain. One of the only indications clinically is best dystrophy. We generally don't, it's quite a cumbersome test. So it's not a great idea to routinely order it in all cases. It doesn't give you many added information in the present day times. As fast potentials, I won't be going into that. Thank you.